We continue now with our month-long series on Alzheimer's awareness with a look into how it affects people of color. Older African Americans are about twice as likely to have the disease as compared to older whites. That's according to figures from the Alzheimer's Association. Hispanics are about 1.5 times as likely to have the disease as older whites.
The Alzheimer's Disease Research Center at Emory University is investigating the reason why minorities are disproportionately affected. Here from the center is Dr. Monica Willis-Parker, Assistant Professor of Medicine in the Department of Neurology. Welcome to the studio, Dr. Parker.
Thank you.
So how is Alzheimer's disease tested, and how does that factor into determining the rates of the disease in African Americans?
The way that Alzheimer's is tested, research has evolved. It used to be kind of like a diagnosis of consensus. You got together all your features. But now we've gotten a little bit more sophisticated. Research has progressed such that we have more tools at our disposal to make that diagnosis definitively. And the workup for it is the same as it is for anybody. It involves a brain imaging study, like an MRI, to look at the structure of the brain. Historically, Alzheimer's is characterized by a shrunken hippocampus, which is a part of your brain. Mm-hmm. All people with Alzheimer's, that is pathologic. That is what you have. A lot of people have different types of dementia. It's not necessarily Alzheimer's, and they may have dementia, but they don't have a shrunken hippocampus, so it's probably not Alzheimer's type disease. So in addition to imaging exams and MRI, we do neuropsychologic testing to see where your brain is working and how your brain works, which is a pen and paper test. I like to say it's the intelligence test for old people. But the other things that we're starting to use now are genes. The genetics, looking for genes and looking for precursor proteins in your cerebrospinal fluid. So part of the workup, clinical workup anyway, involves the brain image, the neuropsych testing, and also a lumbar puncture to look for precursor proteins that are associated with Alzheimer's in your spinal fluid.
Is that a fairly invasive procedure or a painful one?
No. It's not as painful and as horrible as people once thought it was, okay. But getting cerebrospinal fluid is like getting blood drawn from your arm. I'm a weenie, so I don't like getting blood drawn, but, it's no more invasive than anything else.
Dr. Parker, do we know if this disease presents differently in African Americans compared to other ethnic groups?
Actually, that's part of the research question that's being decided.
Really?
Late onset Alzheimer's disease affects African Americans, certainly more so than it affects Caucasian Americans, but African Americans are more likely to live longer with the disease than non-Hispanic whites are. As you pointed out, the different risk factors, African Americans are 2 to 4 times as likely to get Alzheimer's, Hispanics twice as likely as non-Hispanic whites. And we're not sure about why that occurs. There are several major risk factors for all dementias. The first predominating risk factor is age, over which many of us, if you're long enough and gifted enough to live long enough, you're probably going to have some cognitive changes. They're not all going to be due to Alzheimer's, but there are other things besides age. There are genetic predispositions. The genetic makeup and the genes and phenotyping in African Americans may be different from African Americans. You may have heard of something called the ApoE4 gene. Well, ApoE4 gene is associated with the development of Alzheimer's in all groups of people. The expression of that gene may be different in African Americans. What other things can I say that are associated with development of Alzheimer's disease?
Are there any social economic factors you think that we know of?
Actually, yes. Education, the type of education that you got, how much education. Now, why would we say education? Well, first of all, most of these tests were designed for non-Hispanic Europeans, many of whom are college educated. So if you were not well educated being, let's see, at least a high school diploma, and maybe if you were educated in the Deep South where we have issues of deep segregation and educational disparities, you're not going to do well on that test. Functionally, you're doing fine, but you may not be able to recognize the camel or the rhinoceros on the exam.
And does that lead to some kind of false diagnosis then, believing someone has it when they might not?
Well, it's going to give you a lower score, and you're going to have to correct for some of that. But it's sort of like an IQ test. It's biased toward people who have a higher educational exposure. Okay, so that's one thing. So one of the reasons that people of color need to be involved in more testing is so that we can develop more sensitive tools, more culturally sensitive tools for evaluation and diagnosis.
Are there anything specifically that the African American community can do in a preventive measure?
Well, most dementia, and I haven't gotten into the discussion about all dementias, but risk factors for developing any type of dementia have to do with those same things that predispose you towards stroke and cardiovascular disease. So poorly controlled hypertension, poorly controlled diabetes. There's a high correlation between the development of diabetes and the onset of dementia. So controlling cardiovascular disease, any of those things that control for stroke, hypertension, high cholesterol, diabetes, obesity, having a body mass index greater than 30. Those are major risk factors for dementing disorders in any group. But because we are African Americans, we're more disproportionately affected by those things: obesity, diabetes, untreated hypertension, and that's the other thing, untreated hypertension, diabetes, hypercholesterolemia, we're at risk.
We're speaking with Dr. Monica Willis-Parker from Emory's Alzheimer's Research Center about the effects of the disease in minorities. And Dr. Parker, we all know about clinical trials and the lack of participation among African Americans, and obviously this goes back, many believe, to the Tuskegee experiments. So how do you get more people involved in this type of research?
Well, that's an excellent question, and that's one that we're certainly working on. What you will find in this day and age, depending upon how far away you are from Tuskegee, most people would like to participate in research studies. They have not been asked. Now, why haven't they been asked? Many times their doctors aren't aware of studies that they can be enrolled in. Their doctors aren't aware of studies to refer them to. You know, if you're in an academic research center like an Emory or a Duke or a Yale or a Harvard, there are going to be a whole bunch of studies that you can participate in. If you're not associated with an academic medical center, you may not be aware of as many studies that you can probably participate in. But the main risk factor for African Americans not participating in research is, number one, they haven't been asked. I participated in a study with the Mayo Clinic and the Links, a group of African American businesswomen, and it was like, I'd be happy to participate, but nobody's asked me.
So how do you reach the community?
Well, the first thing you have to do is make sure that they're aware that there's an opportunity to participate. There are Emory University's Alzheimer's Disease Research Center is the main one here in the Southeast. There are at least 27 other such centers around the country. Most of them are in academic medical centers that generally have an adjacent minority or ethnic community. So making sure that that community and the providers who are providing primary care and specialty care for these different subpopulations are aware of the opportunity to participate in research is one thing. You can't participate in something if you don't know anything about it, do you? So we have to get more people aware of this. So here at Emory, we have a great Emory Alzheimer's Disease Research Center. We have a brain health center. We have more than 30 funded studies that are in need of participants, black, white, purple, but more importantly, women. Women and African American and Hispanic people. We need all of them.
You briefly touched on studies. Can you talk about any kind of thing in the works as far as studying why this may be disproportionate to African Americans or other minorities?
Well, I think the biggest thing that we're working on are the cerebrospinal fluid biomarkers. You know, there are specific building proteins that are found in the cerebrospinal fluid. You need to have more people who are normal, not just affected, not just ill people. You know, if I don't have any signs and symptoms of the disease, I need to study your brain. I need to study your cerebrospinal fluid to see whether you have any risk factors for this. If your mother had Alzheimer's and you don't, or her sisters don't, we need to see what makes the ones who are affected by the disease different from the ones who are not. You know, so what are we doing? Our big thing is cerebrospinal fluid. We have something called a Project One, where Dr. William Hugh was the lead investigator, and I was his co-investigator on a study that compared cerebrospinal fluid of African Americans and Caucasians with the disease, without the disease, and with something called mild cognitive impairment. And there are differences, but this is a small study, so we need more, you know, to be able to definitively say what makes a difference. We don't know.
I think it's something that's very interesting when you talk about we don't know. I think often people sort of get terms sort of confused, and you wanted to talk about the types of dementia because even my own personal experience in dealing with my father, who he was labeled as having sundowner's syndrome, and then you heard about dementia and so forth. So let's there are different types of dementia here.
And that's a real important one, because I'm always asked, what's the difference between Alzheimer's and dementia? And the way we describe dementia in simplest terms is that dementia is a broad term. And there are different types of dementia. Alzheimer's has been the most commonly diagnosed dementia, followed closely by what we call vascular dementia, which is related to stroke-related disease. So if you've had a mini stroke or a stroke, it kills off some of your brain cells. It's not working. So if you have risk factors for Alzheimer's, you've got that Alzheimer's there, and you've got the vascular. But maybe you've got Parkinson's disease. Parkinson's is another neurodegenerative brain disorder. So you're somebody who's 75 years old, you're a Caucasian male, let's say. You may have features of Alzheimer's, you may have features of Parkinson's, and you may also have vascular features, because most people who are in their 70s and 80s are on more than multiple medications to control their heart disease, their hypertension, their diabetes, their Parkinson's. So when you start talking about dementia, there are different types of dementia, and the treatments for each of those dementias and the presenting signs for each of those dementias may be different. The end result, the final destination for most of those dementias is the same. It's an individual who can no longer care for him or herself, needs assistance with activities of daily living. Activities of daily living are things that all of us do, are feeding, toileting, ambulation. Things like that. That's basic. As a person progresses with their dementia, they're not able to manage their own activities of daily living. Instrumental activities of daily living, things like cooking, following instructions, driving a car. Most people who are starting to have problems with dementia are starting to have trouble with those things. For the most part, they're still dressing themselves, feeding themselves, and toileting themselves without a whole lot of difficulty. So again, you have many different types of dementia. As research goes along, we're finding out about different types. There are findings in some autopsy studies that a lot of African American brains have features consistent not so much with just Alzheimer's, but with more like Lewy body dementia. That's another type of dementia. So they have different things that they're looking for.
Talk more about that. What would they be looking for, whereas in an African American patient, as far as or compared to a Caucasian patient?
I think scientists aren't looking for anything in particular. They're just trying to see where we're similar and where we're different. On autopsy, like I said, you're looking for the pathognomonic feature of Alzheimer's is something called plaques and tangles. Have you heard those terms before?
Sure.
Okay, so on an autopsy specimen, you're looking for those plaques and tangles, but you may see other things. And those other things may tell you that it may be a different type of dementia. It's just which features are predominant. You may see the features that are associated with the vascular dementia. You may see the features that are associated with Alzheimer's. You may see features that are associated with Lewy body, and other pathologies. It's like, what are we looking for? We don't know what we're looking for. We're trying to see what there is. And that's why we need to see more people who are different. Most of these studies have been done on European males, not even European females. So we also know that females are more likely to develop dementia than males are. And it has less to do with age and maybe more to do with that gene, the genetics of being female.
Dr. Parker, as we wrap up here, when you think about all the research that you've been involved in and what needs to happen, is there any sort of projected timeline in terms of when we're going to be close to being able to even have some type of medication or therapy treatment for this disease?
We're closer. We're closer today than we were 5 years ago or 10 years ago. But with more funds, federal funds, pharmaceutical funds expended in the effort of figuring out what works, we're closer. Certainly by 2025, hopefully we'll have more disease-modifying drugs available. Currently, the 4 drugs that we use to treat Alzheimer's, donepezil, which is known as Aricept, Exelon, and galantamine. What's the word? I'm trying to think. I can't think of it right now. But those are 3 cholinesterase inhibitors and Namenda or memantine. Those are the 4 drugs that we have available to treat the symptoms of disease. None of these drugs cure anything. They're not like chemotherapeutic drugs. What we're trying to do is get to the point where we have a chemotherapeutic type drug that actually stops and changes the course of the disease.
Our guest has been Assistant Professor of Medicine, Dr. Monica Willis-Parker from Emory University's Alzheimer's Disease Research Center. Thanks so much. We appreciate your time.
Dr. Parker.